Hello, everybody. Assalamu alaikum. Good afternoon, good evening, or good night, depending on your time zone. We meet again, and it's a new day. The poll on Telegram has the highest votes for Station 5. So, Station 5, it is. Station 5 is essentially the same as the long case of the MRCBI with a little bit of modification because you will be having some more history included since you have more time. We can modify the approach and compensate for that during the discussion. So the thing about Station 5, if you have done this before or not, depending on your level of preparation, it is the same. Meaning that Station 5 there is maybe 60, 70, 80, 100 cases. Who cares? I'm not going to memorize 60 or 70 or 100 cases. Instead, I will have a template. I will have an approach. And this approach will divide cases into categories. So essentially, Station 5 is going to be around 5 main categories. Those are 1, rheumatology, all the rheumatological cases. 2, autoimmune conditions. 3, spot diagnosis. Once I will see it, I will know it. 4, and this is my favorite one. And lastly, 1 for emergency or acute cases, which is to be common in the exam. Alongside, there are 3 to 4 cases I would call sporadic cases. Those are the ones that I will have to actually memorize them. Rheumatology, there are multiple cases under rheumatology, multiple cases and autoimmune, and each approach will deal with each case in the same manner that you will deal with others under the same category. Let's get a practical example and do that right now. Dr. Sama, he did ask for the first case. Are you there?
Yes, Dr. Hassan. I'm here.
Okay, it's always good to hear your voice, my friend. Let's
Thank
get
you so
things
much.
in order, and we will start by one of the simplest, most common cases in Station 5 to see how it will go. And in that case, there is a 25 years old lady who has been complaining of a skin rash for the past 6 months.
Okay.
Can you guess what kind of a skin rash is there?
From now or after I will just...
Now. When you see the patient, you will know, but you have 5 minutes outside before seeing your patient.
Okay.
Can you guess what kind of skin rash?
So, of a skin rash for 6 months, I will think of the, as you put, dermatology, the autoimmune.
Exactly. So I cannot guess which case is that. What rash is that? Meaning it can be virtually anything.
Anything.
And anything means that once you see the patient, you will get the diagnosis and you will act accordingly.
Yes.
With the stress of the exam, having something memorized to take it or to recall it immediately once you see the rash is going to be difficult unless you have an approach.
Yes.
And that's why this is what they do in the exam. Meaning, they are not giving you something that you are not familiar with. In fact, you are so familiar with it, but the problem is always that you will forget something, God forbid, not you, but most of us will forget something because you will not be able to recall everything in time. So let's see how it will go with you. If you want to prepare your paper, carry on. For the time being, we get 5 minutes before seeing our patients in the real exam. And again, I will divide my paper accordingly before seeing the patients. And this is huge in the exam. As we have done in Station 4 the previous time, we will put the name of the patient on top. Next to that, I'm going to write down my task, or I would say the presenting complaints. And the presenting complaint, this is one of the major problems in Station 5. As easy as that. We'll get to that later. Then, in the middle third, as usual, I will put the items of the history, which includes social history. There are 7 items. There is past history, medication history, and family history. And down there, I have an approach. The approach should be according to the case in hand. But since I am not aware of the case because I did not see the rash yet, I will stick to the fact that I will go through each case systematically if I do not have an approach, and that is one, analysis of the presenting complaints. The presenting complaint analysis goes into 8 out of 8 points. From now on, you will see everything in numbers. I hate paragraphs. I have to know how many points in each category. After the complaints, usually I get the system involved. Meaning, if this is a case of a headache, I will go CMS. If this is a case of constipation, I will go GIT, and so on. So here we have the system involved. Afterwards, I will get my differential diagnosis in order to reach a diagnosis. Ideally, all those steps should be under 4 minutes. At most 4 minutes, 2 minutes or even less in some cases. Following that, after getting my diagnosis, I will start examining the patients. After getting the examination done, I will need the history part in order to offer help, as we have discussed before. Then I will wrap up the case by asking about the concern. So here comes the closure of the case. This is the general outline for station 5, and it should be the same for the MRCBI long case, with one exception, is that between step 3 and 4, here I will need a systemic review, history-wise. I will need to cover all the systems, question by question, in order to get it for the MRCBI. But the order is the same. Whenever you are targeting station 5 or to study station 5 or even station 2, please have 3 different papers. One paper will be for your own practice. One paper for the differential diagnosis, and one paper, we will call it the pitfall paper, the infamous pitfall paper. This is what the exam is all about. This is what they do in the exam, and this is why the exam is not very easy, because they focus always on the pitfalls. If you're aware of the pitfalls, aka khawazik in Arabic, as I call it, things will be much easier. So this is the general outline for station 5. Let me prepare some photos for you, Dr. Sama, and we will get on right away.
Okay.
I'm not going to interrupt you during the discussion. I will leave it till the very end, and I will kill your headphones if you miss something. We have been together for a very long time.
Okay, sure.
Okay. Just give me a second here.
Sure.
Okay. Let me set the timer as well. The timer is on and go.
Okay. Good evening, Mrs. Stewart.
Good evening.
I'm Dr. Sama. I'm the senior house officer in the clinic today. Are you Mrs. Stewart, 25 years old?
That's right.
And we are here today to discuss about your health problem. You came in with complaining of skin rash. Can you tell me more about it?
No.
Can you show me the rash, please?
Sure. The rash is coming up on the screen. That's it.
Okay. So since how long this is happening?
6 months.
And is it more and more day by day?
Yes, it's getting bigger over time.
I see. Anything make it worse, like exposure to sun, exposure to trauma or something?
Not really sure.
I see. Anything make it better? You're using any medications or?
I have seen the GP, but he didn't give me anything that has improved the condition.
And did you notice any anything associated with this problem?
Like?
Any feeling of dizzy? Any feeling of loss of energy?
No.
Any fatigue?
No.
Is there any area other than this? I can you can show me, or only this?
It's on both my hands and my knees.
I see. Any joint pain?
No.
Any change in the weather preference?
Not really, no.
Any swelling in front of your neck?
No.
Any hard motion and soft motion?
Change in bowel habits? No.
Any change in your water work?
No.
Any pins and needles?
No.
Any dizzy when stands from sitting position?
No.
And do you feel thirsty or something like that?
More thirsty than usual? No.
I see. And did you had any headache?
No.
I see. Any tummy pain?
No.
Okay. I would like to ask you more questions about this. Is there any pain anywhere?
No.
Miss, I want to start to examine the patient.
Sure. What would you like to
So
examine?
I will just look at the skin rash. I will immediately go to the pulse. I will just look in the skin rash
The
on the
pulse
hands,
is regular,
face.
80
I
beats
see.
per minute. Average volume equal bilaterally. No specific.
Blood pressure.
130/80.
I see. Proximal myopathy.
Negative.
And I would like to look at her eyes and mouth. If there is anything inside the mouth sores or change in the color of the mucosa.
No pallor, no jaundice, and there is no discoloration in the oral mucosa.
Any weight changes?
No.
I will just examine the thyroid from the behind. I will just ask her to swallow.
No need.
I see. And I will just go to the lower limb. I will just see if there's any edema.
There is none.
Nothing. I see. Mr. Stewart, do you notice what are you smoking?
Yes.
How many cigarettes a day?
10 cigarettes per day.
For how long?
For the past 3 years.
I see. And did you think about stopping? Because this affects our health in general, but very important to know if you have any intention to stop it, because it's in general we have to stop because it can affect our health. Is that okay?
Thank you.
And you family history of note?
No.
And any similar condition run in the family?
No.
Any disease run in the families?
No.
Any past medical history of note?
No.
Any history of admissions to the hospital?
Never.
Procedures?
Nope.
Do you smoke? Do you drink alcohol?
Nope.
I see. And what about your job, Miss Stewart?
I am working as a secretary.
And does this problem affect your daily work activity?
Yes, very badly.
I'm really sorry for hearing that. We will try our best to help you as much as we can, and we'll refer you to the occupational health officer
And
the social worker.
thank you.
Okay. And does this? Okay, Miss Stewart, what is your main concern?
What is going on with me? What do I have?
So it seems that this rash that you're having in your hand most likely secondary to a condition called vitiligo. Don't bother yourself with the name. It's a disease or condition that happens secondary to a problem in our defense mechanism when it starts to attack our skin, our body parts as a foreigner. So we need to form a multidisciplinary team for that reason, and we need to involve a skin doctor. We need to involve also other doctors and do blood tests, run certain images also, and then we will inform you immediately what about our plan. Is that okay?
Thank you. I appreciate it.
I see. Ms. Stewart, Ms. Stewart, do you have any, I'm sorry for asking this prior question, but I ask it to all of my patients. Do you have any problem in your period?
Finally. No, thank you.
I see. And are you taking obstructive or contraceptive pills?
No.
I see. And you're married?
Are you in any long-term relationship? No.
Sorry. Okay. And you're living with whom?
Alone. And let's fight now. Time is up. Let's get into a fight.
Yeah.
Examine their questions first, but before all, you have done very well. Obviously, the diagnosis is very noticeable, and this is a vitiligo. But why do they bring vitiligo in the exam? This is the issue. So to start with, your diagnosis is vitiligo, right?
Yes, but I didn't find the association. Yeah.
Yes.
Yeah.
Any autoimmune association?
What do I look for is the rheumatology, the endocrine, the other autoimmune like pernicious anemia, diabetes, celiac disease. I looked for premature ovarian failure. I looked for, that's what I looked for. Also, I looked for, ITP.
Okay, Dr. Asma has a question for you, and that is, why did you ask to examine the thyroid?
I examined the thyroid because it's part of, it's very common to have Hashimoto and autoimmune thyroid disease with vitiligo.
How common?
More than 70%?
No. But it is the commonest autoimmune
It's the
association
common.
with vitiligo.
Yes, yes. It's the most common.
Okay. Overall, that's a very well done case, Dr. Sama. Thank you so much. Now let's get things in order. Me and you getting the stuff that we did not get to cover properly. First of all, approach for this case is simply an approach for autoimmune conditions, meaning that we will do the same for every single autoimmune condition out there. For autoimmune conditions, I have 3 tasks. What are those? Do you remember?
Yes. Association.
Associations.
Association. Triggers or precipitating factors. And complications.
So this is simply the approach for any autoimmune. Associations, those are how many?
So there are 6. First, biology.
Okay, carry on. What else?
Okay, so thyroid disease.
Carry on.
And pernicious anemia, autoimmune hemolytic anemia, and diabetes, premature ovarian failure.
Mm-hmm. So how many are those?
Those are 5.
Or 6?
Yeah, 6.
6. So we have seen mainly 6 autoimmune conditions, and this is applicable for whatever kind of case you are dealing with as autoimmune in station 2, station 5, and in the long case of the MRCBI. I have to rule out them one by one. How do I rule out Addison?
So any dizziness when it starts from sitting position, any change in the color of skin, any hypoglycemia and
hypoglycemia symptoms and hypotension, postural hypotension, those are the most specific ones that we need to be looking for. Agree? Sure. Thyroid.
Agree. Period and change in the weather preference.
Okay, we'll move on to the pitfall or the pitfalls paper. In the pitfall paper, 1 thyroid in a female equals
female history.
Female history, not period.
Yes. Okay.
Female history, how many points?
3 related to the period and 3 non-related to the period.
Perfect. So female history is essentially a sex history. So this is 6 points in total, and those are 3 points to the period, which are
is it regular? What about the flow? And last one.
Okay, and the 3 other ones that are not related to the period directly?
So abortions, C-sections, C-sections,
C-section is not. Delivery.
Sorry, delivery.
In any form, whether normal delivery,
normal or C-section delivery.
C-section. Yeah. And the last one is
OCP.
OCP. So we have 6 points for the sex history or the female history whenever it comes to thyroid. The only clue to thyroid problem in the exam is going to be the female history. Weather intolerance, whether hot or cold intolerance, weight changes, bowel habits, shaky hands, all those can be precipitated by other conditions. Standard pitfall in the exam, and that's why it is number 1 in your pitfall paper in every single diet. You can get hypo or hyperthyroid picture from other conditions. However, the only clue is the female history. If the period is irregular, scanty, this is hyperthyroid. Irregular, high volume, menorrhagia, hypothyroid. If the period or the female history in general is normal, this is euthyroid, regardless of the symptoms. Agree?
Agree.
Agree. This is the first point in the pitfall paper. Moving on, second point in the pitfall paper. In station 5, once you have a skin rash or a joint pain or a joint swelling, the first thing that you should say to the patient is,
show me.
Thank you. Not tell me. Show me. The diagnosis lies in the rash. The diagnosis, once you see the joint, you will identify what is going on. Save your time, save your case, save your day, and ask him to show you the thing or the problem immediately. Hello, I'm Dr. Hassan. I'm here to examine you and to take some history from you. Can I do that? Yes. Can you show me, please, the problem? show me the joint, show me the rash, show me whatever. Easy. Moving on. Third point in the pitfall paper. Analysis of any symptom. How many points do we have?
So previous onset, course duration increasing, decreasing, association, it's 8 plus 3. Yeah.
This is the main problem. When you get in the exam with a stress, you will forget unless you know how many points you are discussing. This is why I'm emphasizing the points one by one, not paragraphs. 8 out of 8 standard for any symptom. Previous, which is a very common missed one, and this is a very common pitfall in the exam. Previous, onset, course, duration, exacerbating, relieving factors, and those have to come with examples. Association and timing. Associations, we are focusing on twins. Those are two symptoms that usually come together, and whenever you ask about the first twin, you have to ask about the second twin immediately. The most important twin in your life till you pass this exam is going to be
headache and
vision.
headache and vision. Others like
polyuria, polydipsia.
polyuria, polydipsia. Others like night sweating, lymphadenopathy. Others like nausea and vomiting. Others like whatever. But this is going to be the most important one for you in the exam. Timing has 2 questions. By the way, this is generally speaking for whatever symptom, not related only to the rash. Timing has 2 questions. What are the questions for the timing, Dr. Sama?
I didn't ask, yes. Because
I know, it's not applicable here, but generally speaking.
They are not, so in case we have the differentiation in IBS, and also we have to also polydipsia.
To the point, timing, 2 questions. 1, diurnal variation. Does it get worse in the morning, better in the evening, or vice versa?
Does it wake you from sleeping?
Thank you. Does it awake you from sleep? Awaking someone from sleep will mean that this is not a functional problem. This is an organic problem. Namely, in the exam, and this is very common in the exam, something like IBS can be excluded totally by someone who's being awakened by the need to go to the toilet, versus psychogenic polydipsia, versus tension headache. All those just by simple question to the patients. This is standard for whatever symptom that you have. Agree? Dr. Sama, following?
Following.
8 plus 3 out of 8, you will add 3 more points if this is a case
In case
of
pain. Yes.
pain, just pain, tummy pain, whatever kind of a pain, you will add
Character, radiation, and severity.
score, nature, and radiation. The score is very important, especially in cases of headache. The nature of the pain is irrelevant. And this is another pitfall in the exam. The nature of the pain is irrelevant until you have a diagnosis. Meaning, an MI can present with burning pain, or stitching pain, or electrical pain, whatever kind of pain, but it does not rule out an MI. This is the standard pitfall in the exam. They give you atypical nature of pain for a serious diagnosis underlying. And once you consider the diagnosis just from the character of the pain, the case is gone. Following?
Following.
In a case of diarrhea or a case of a rash, you can add the questions that you usually ask about, like the color, the size, whatever, itching or not, the skin overlying, all this crap, but you will not need in station 5 because you already have seen the rash. Moving on. Let's get to the associations are done. Triggers. What are the triggers of vitiligo?
So, stress usually, and
what else?
I think
Sun
I'm not
exposure?
sure about the sun exposure, the alcohol, smoking, medications.
Nope.
Sun exposure.
Look at the screen.
Certain type of trauma. Yes.
Kopner's phenomenon. So those are the associations. Those are the triggers. And finally, the complications. Complications in general are either from the disease itself,
or its complication from the medication.
Treatment of the disease. And the most common form is going to be
Steroid side effect.
Steroid side effect, namely
Sugar and pressure, diabetes and hypertension.
diabetes, hypertension, weight changes, along with osteoporosis.
Porosis and back pain.
The disease itself, all the autoimmune conditions precipitate disfigurement because most of them are skin rashes. So there is the psychological impact of this problem, with one exception only, which is psoriasis. Psoriasis, apart from having the complications from the disease, the complications from the treatment, it also has the complication of being,
Cardiovascular risk.
thank you, metabolic
Metabolic syndrome.
disease. Meaning that cases of psoriasis most likely are going to be associated with, yes, say it.
So hyperlipidemia, diabetes and sugar pressure, so hypertension, hyperuricemia.
And diabetes with weight changes as well. And that's why it is very common in a case of gout to ask about skin rashes. And that's why one of the main presentations of psoriasis is someone with poorly controlled hypertension, knowing that most medications for hypertension will exacerbate the psoriasis. Standards for the exam. Agree? Agree. So, stepwise for this case, I will start with one analysis of the presenting symptom. As we have mentioned, the symptom, this here will go 8 out of 8. Whatever is applicable, you will apply it. Moving on, analysis of the system involved. Do we have any system involved here? No, but this is an autoimmune, so I will start hitting the associations to get them done. Then the triggers, and the triggers can be covered in the analysis and the exacerbating factors if you wish to, and the complications. Then I will move to examine the patients. Examining the patient goes into 2 steps for whatever case, not only in this case. As I told you, station 5 is very easy if you have a scheme. That's it. So examination, there is the basic examination that I do for every single patient in every case, regardless of the presentation. It takes 15 to 20 seconds, and it's pure inspection. Looking at Dr. Sama, dorsum of the hands. Ask the patient to lift his hands. Palmar. Then
Palmar.
the next joint, which is the wrist. Then the next joint, which is the elbow. Go joint by joint. Imagine the patient. Visualize the patient in front of you. I will meet everyone. Unmute yourself, Dr. Sama. So the elbow will be for blood pressure. Then the shoulder for proximal
myopathy.
Then I will take a look at the eyes for jaundice. Then I will ask the patient to open his mouth to look for whatever deformity and do not memorize deformities. This is standard for whatever case. If I have a leg ulcer, I will start this way. If I have a chest pain, I will start this way. In the clinical exam, clinical stations, in the abdomen, you start from the hand. In the cardio, you start from the hand. In the chest, you start from the hands. So, standard, and this is something that you are totally familiar with, and it will give a very good impression to your examiner, and it takes 15 to 20 seconds. Then comes the targeted examination. And this is one of the most common problems in the exam. When you did write down your paper, and this is a very common fact killer in the exam. You wrote down the name of the patient on top of your paper, then you wrote down the presenting complaint. The presenting complaint here, this is your targeted examination. Why do I stress this point? Because some patients with rheumatoid arthritis hands, for example, they present with a back pain. So the presentation in this case, Dr. Sama, is back pain. What happens in the exam? Can you guess?
In the back? You mean the target? I have to examine the back. The patient, the surrogate.
But
so you went to the hand. Yes, we'll go to the hand. Yes, in the exam, the stress.
Yes, they will go for the hands for getting the presenting complaint, and this is minus 10 marks right away because you didn't examine the presenting complaint. That's why keeping you on top of the paper in front of you at all times is critical. What I'm saying here is based upon experience, based upon my own mistakes in the exam. I have taken this so many times, and I have failed so many times, and I have seen it so many times. So this is being so realistic for the exam. So 1 is the history, and we have covered it. 2 is the examination. Targeted examination here. What are you going to do for target examination? Just stare at the rash, or there's something else that you need to do?
So I have to just make sure that I examine the thyroid
Offer
gland. I have
the thyroid. Thyroid, you are absolutely right. Offering to examine the thyroid because the thyroid has the most likely autoimmune association with vitiligo. This is textbook. So you have to offer the thyroid, otherwise there is no mark for the clinical examination. And I'm mentioning that frequently. One of our friends, one of our doctors, once in the old times, she failed the entire exam because in a case of vitiligo, she didn't examine the thyroid, although the lady had no thyroid problems. But the examiner found that not examining the thyroid in a vitiligo is a fatal mistake to fail the entire exam. So please don't forget it. Then comes the history part, and that is social history, past history, medication history, and family history. Social history. Why do I take social history, Dr. Sama?
to offer help. To offer
How to
help.
offer help? You will ask about
Job.
and whom is this patient living with?
Daily.
Different implications. Do you think that your symptoms are affecting your job and your daily activity? Yes, I'm sorry for that. I will involve the occupational health officer and the social worker to help you regarding this issue. This is standard for station 245 or the long case of the MRCBI. Saying that would be enough. What is he going to do? This is not of your business. This is his job. Past history, any past history of notes, all this is shared in the PDF, how to ask questions. It's very simple, 2 papers or 3 papers in the PDF on the groups. If someone can resend it in the Telegram, it would be awesome. Any past history of notes, then you specify diabetes, hypertension, hospital admission, whatever. Then the medication history. How many questions for the medications, Dr. Sama?
The medication itself, compliant with it, any side
No.
effect, any changes
No.
in those.
This is if the patient is maintained on a medication. But once you would like to know if he is taking a medication, you will start 3 questions. One is show me your
The
medication list.
medication list. Over the counter.
Over the counter medication. And 3,
Drug abuse.
how would you ask about illicit drugs?
Sorry to ask about this.
Yes, sorry to ask this question that I do ask to all of my patients. It means that you do not characterize him or see him as an addict. This is important for the welfare. If you ask him, do you use any illicit drugs? The usual answer is, do you think I'm an addict? You do not want that in the exam. So, can I see your medication list, please? Any over-the-counter medication? I'm sorry to ask you this question that I do ask to all of my patients to use any illicit drugs. And as usual, whatever is applicable here is applicable for station 2 and station 4 and station 5 and the long case of the MRCBI. Moving on, and by the way, over-the-counter medication is a very common trick in the exam. Illicit drugs are a very common trick in the exam. So asking about this explicitly, very clearly, means that you do consider it and the examiner cannot pretend that he did not hear you asking about it. Then the family history. How many questions do we have for the family history, Dr. Sama?
3 questions.
Which are?
Any similar condition in the family? Any disease runs in the family?
And?
Similar condition, any disease run in the family, and the family history of note. Okay.
Why family history of note is a very important case. Typical example throughout the exams. Lastly, indicted 319. And by the way, it was also in 219. And guess what? It was in 119. As far as I can remember, it is always there. The family history is a problematic question. So make sure that you ask 3 questions. Typical example from this diet was a case of hematuria. The diagnosis underlying that is polycystic kidney disease. Adult polycystic kidney disease. The problem is this patient's family history has only a stroke in his father at a young age. You want to establish the familial inheritance of adult polycystic kidney disease. So you will ask the first question, any similar condition in your family, hematuria? He will say no, and he's right. Secondly, any disease that runs in the family, hematuria or whatever, no, and he's right. If you stop there, there is no familial link. 3, any family history of note, sudden death, or cancer? This is the proper question, and he will tell you I have a father who died with a stroke. At what age? At the age of 25 or 30 or whatever. Without this question, the case is gone. And this is a very common case for whatever familial condition, especially in GIT exam-wise. They love it in GIT. Following, Dr. Sama?
Following.
And mentioning the GIT, we will add one more point in the pitfall paper that there is no, let's put this as number 4.
No GIT without a history of cancer. Or without rule out cancer.
No GIT without ruling out cancer, regardless of the age, regardless of the presentation. As long as the presentation is related to the GIT, cancer comes first. And how do you rule out cancer?
Change the color of skin or pallor.
I will tell
Family
you.
history.
Color?
History, family history.
Cancer of whatever sort, of whatever organ is ruled out through? No, this is not the answer I'm looking for. The answer is clinical picture and family history. This is the reflex that I want you to remember.
Clinical picture and family history.
The clinical picture and the family history. And the earliest clinical picture of cancer,
Is pallor.
everybody forgets, pallor. Iron deficiency anemia. They look pale, they look sick, along with the rest of the clinical picture. But pallor is the earliest one. Family history, now we know how to ask about it in 3 questions, not in 1 question. So how do you rule out cancer, Dr. Sama?
I didn't ask for pallor specifically, but I asked about skin changes.
I know. I'm talking in general. I do not care about the diagnosis.
Okay, so pallor. Yeah.
Oh,
So
the answer is, how do you rule out cancer?
by asking the family history, and do you have any change in your color of skin?
This is not the answer. The answer is simple. Clinical picture, family history. Again, how do you rule out cancer?
Clinical picture and family history.
Why I emphasize that? Because everybody forgets that in the exam. Very easy, but very commonly forgotten in the exam. That's why keep it simple. Clinical picture, family history. This is the answer. Then ask whatever you want to ask about. So this is 1, the history. 2 was the examination. 3 was the rest of the history that I wrote down in my middle third of the paper, and that was to offer help. Mentioning the social history, there is smoking and alcohol. Smoking, when the patient is a smoker, you want him to stop smoking, correct? Correct. So please tell him to stop. Because I didn't hear you tell me stop smoking, please. Keep the message simple, to the point, without wasting time. Do you smoke? Yes. How many cigarettes per day? And for how long to get the smoking index? Whatever index there is, even 1 cigarette a day, he should stop. So the proper answer is, smoking is bad for your health. So I strongly advise you to stop smoking. Advise with an S. This is the verb, because everybody mixes that with the advice, which is the noun. Piece of advice, but advice.
Yes, advice.
So I advise you to stop smoking, and if you need help with that, I can refer you to smoking cessation clinic in our hospital. That's it. It takes 10 seconds. Alcohol. What is the recommended limit?
Less than 14 units in male and less than 12 units in female.
Less than 14 for both of them. Yes. If the patient is drinking more than 14, what should be the advice?
I have to tell him to moderate. I will ask him to moderate. Only I will advise him to moderate, not to stop.
Moderate or to stop?
Moderate.
Moderate. When to tell him to stop completely?
In case of liver disease and chronic pancreatitis.
Very true. If the condition is directly related to alcohol, meaning this patient has alcoholic neuritis or alcoholic neuropathy, you will ask him to stop. If this patient has an acute pancreatitis because of alcohol or chronic alcoholic pancreatitis, you will ask him to stop. Or the liver is damaged, you will ask him to stop completely. But otherwise, ask him to moderate or to decrease the amount of alcohol he's taking because it is harmful for his health. Agree?
Agree.
Agree. So we did cover how to tackle the case, starting from the history, the examination, offering help, and lastly, the closure of the case. How do you close the case? You have closed the case perfectly. I will start, and this is standard for station 2, 4, 5, and the long case of the MRCBI. This is why I do not care about a single diagnosis whatsoever. You can get whatever diagnosis in the exam, but having a proper template makes all the difference. So I will start always with the presenting complaint or the presenting symptom. Then I will name this diagnosis. What is my diagnosis? Then I will define the diagnosis. And for that diagnosis, I'm going to form a multidisciplinary team. And this team will run some investigations, blood testing, imaging, with or without a camera test. And after getting the results, we will have another meeting to discuss the results and the plan of management, with 3 points to be put in mind, which are:
Follow up.
if you are going to admit the patient, you have to tell him. If you want him to start or to stop a certain medication, you will have to tell him. Or if you will
Start painkiller.
give him a proper painkiller for his pain if he's having pain and it is applicable or okay to give him a painkiller. So applying that to your case, this lady has a case of vitiligo. Vitiligo is essentially an autoimmune condition. So what do I have, doctor? I'm sorry to tell you that the rash, let me put this in a different color. So the rash you have been suffering from is related to a condition called vitiligo, and that is an autoimmune disease. By that I mean a disease that is affecting your immune system. That is the system defending our bodies against infections and bugs. In your case, it is misdirected to attack your body, causing your symptoms. And for that reason, we will form a multidisciplinary team. The team will run some investigations in the form of blood testing and imaging, if needed, and we will arrange for another meeting to discuss the results. For the time being, I advise you to take a painkiller. If it is vitiligo, so there is no advice here except avoiding the sun, maybe. If you want to mention that. That's it. So how much time does it take to close the case? Less than 30 seconds. And this is very practical for the exam. Other forms of, after seeing you, examining you, and taking history from you, I see that you are wasting your time. You have no time for that in the exam. The point here is that you have to be realistic. What you do in your practice should be what you do in your exam. That's when you get to see the patient in the exam, you are not shocked. And believe me, this is one of the most common things in the exam. People are shocked. They have seen psoriasis 100 times before, but they have no idea what to do. They have seen vitiligo 50,000 times before, and they have done it online 10 different times. But when they see a real patient, they do not have no idea. They have no idea what to do because they did not practice that way. This is what they need for the exam. So overall, it's a very, very well done, Dr. Sam. If someone can share that PDF,
Doctor, please, for vitiligo, we ask for multidisciplinary team.
Yes. Why? Does this patient need help? Yes, she needs the occupational health officer, social worker. Does she need any help from the derma? Yes, she needs the dermatologist. Does she have any autoimmune association or not? She will need an internal medicine. Are those a team or not?
Yes.
They are always.
The family doctor also have to know, and he have to just make sure.
There is always, keep it simple. MDT is the approach for whatever case. You will never, ever deal with the case alone. This is an exam for a SHO. SHO, it is totally okay in the UK, and whoever here is practicing in the UK knows that very well. You will never take a decision from you on your own. You have to refer it to the consultant. Everybody's trying to keep himself or his ass safe, if we say that. So he will never take a decision alone. He has to have a multidisciplinary team, and the multidisciplinary team for us essentially means the consultant, or you remember that from yesterday, the building owner. الحاج صاحب البيت. Me, I am simply the doorman. Make sense?
Makes sense.
Okay, any question here, anyone? Thank you, Dr. Sama.
Thank you, Dr. Hassan. Thanks a lot. Thanks a lot. Really.
Any question here, anyone?
So, sir, in this vitiligo case, what will be specific differential I can put here?
Do you think that you have a differential for vitiligo in the exam? No.
Spot diagnosis.
Yes.
For diagnosis, yes, sir.
There is something that looks like vitiligo, which is a completely, well, I would say not completely, 99.999% of the time will never be in the exam. So why should I waste time there? To ask about sensation or to ask about skin trophic changes. Leprosy. How common do you see leprosy in the exam? No way. So this is a vitiligo. Plus, from the very first look, vitiligo is affecting the parts of the body that are more likely to be traumatized. That's why it's usually on
Hands.
Around orifices, like eye orifice, hands.
elbows,
Knees.
knees, orifices, the face, but it is very uncommon to find it on the back. So from the very beginning, this is a young lady with an autoimmune condition. If you want to ask about the sensation to rule out leprosy, fine. But if you are not going to take the exam in a center known to have leprosy on, then no need to have a differential. The point here is you will find a lot of details in the book, but what the examiners are actually looking for is what we are discussing. Anybody can read that from the book. Vitiligo in the book is something like 4 or 5 pages or whatever, more than that. But now you have vitiligo done in one paper. I know what is the problem, I know what are the pitfalls and how to cover it. That is what you need for the exam. Any other question?
Then this is Dr. Hassan for any spot diagnosis in the exam. This is the
This is
approach
not
for
spot
association
diagnosis.
trigger.
This is autoimmune. Cases for autoimmune are
Yes, autoimmune. Okay.
like vitiligo. What else?
Psoriasis, pemphigus, pemphigoid, pemphigus, pemphigoid, Addison disease.
Addison is not a diagnosis per se from the very beginning. What else?
I think porphyria cutanea, but I'm not sure if it is
No. Something more important like?
myasthenia gravis. Okay.
Thank you.
Sure.
So there are 3 skin rashes and myasthenia gravis, which is a very common presentation in the exam because they do not need an actual patient for it. There is always a surrogate for that case. And those all of them will follow the same points, association triggers and complications. Now, I'm not sure if anyone can share the PDF. It's on my phone, not with me at the moment. If you can share the PDF on Telegram, it would be awesome. The PDF for the history and the structure of communication. It's a very small one, like 3 papers for each. Very good. Anyway, it's a good session, everyone. The next time we will have another poll. Hopefully station 4 if you want to, or not, we will continue with the station 5. It's up to you. So please participate in the poll, and I am ready to do whatever case you want to do. But please try to enjoy it and try to be consistent. You need it before the exam because soon they will open up everything and you will have a chance at taking the exam again. So start preparing, do your best, and I will be seeing you guys tomorrow, inshallah. Take care, everyone.
Thank you, Dr. Hassan.
الله يسلم ايديك يا رب.